Thank you for joining us for this Chronic Disease Day live stream event on addressing health disparities and promoting health equity. My name is Clorinda Wally, and I am the president of Good Days. As chronic illness impacts more and more Americans each year, Good Days is leading the charge behind Chronic Disease Day. We created this awareness day to recognize that 7 of the top 10 leading causes of death annually in the United States are due to chronic disease. The most staggering part of this number is the majority of those are preventable. Chronic Disease Day raises awareness so that together we can all create positive change. As a Hispanic woman, it's very concerning reading statistics from the Center for Disease Control, which indicate that 8 in 10 Hispanic Americans are considered obese, leading to a variety of life-impacting chronic conditions. Hispanics also have the highest uninsured rates of any racial or ethnic group in the US. Addressing these health disparities and promoting health equity is an important facet of this mission. Thank you to HealthCentral for collaborating with us to host this very timely event. We have an excellent group of speakers today, including HealthCentral's Executive Editor, Julia Savakul, and Dr. Nathan Stinson Jr. from the National Institute of Minority Health. We also have very special remarks from congressional leaders who are championing healthcare policy in their communities. First up, I'm excited to introduce remarks from Representative Lauren Underwood of Illinois. She is the youngest African-American woman to serve in Congress, who also happens to be a registered nurse.
Hi everybody, I'm Lauren Underwood, and I have the honor of representing Illinois' 14th Congressional District. I'm delighted to be joining you for this important conversation about health disparities and the role that public and private health systems can play in promoting health equity. As a registered nurse and former senior advisor at the Department of Health and Human Services, I spent my career working to lower out-of-pocket healthcare costs, eliminate barriers to care, and promote equity in healthcare access and outcomes, priorities that have become even more urgent since the start of the coronavirus pandemic. The disproportionate toll of COVID-19 on communities of color has forced our nation to reckon with disparities that existed long before the virus started to spread. And as we emerge from this pandemic, we need to take bold action to address the underlying causes of these inequities, including systemic racism itself. A critical first step will be ensuring that every American has high-quality, affordable healthcare coverage. I introduced the Healthcare Affordability Act to lower out-of-pocket premium costs and expand access to care for uninsured Americans, while also providing financial relief to individuals and families who've been struggling to afford their plans. I'm proud that provisions of my legislation were included in the American Rescue Plan, and I look forward to building on this work to ensure that no one in our country lays awake at night wondering if they're one illness away from bankruptcy or one job loss away from losing their coverage. But health insurance alone does not guarantee access to the treatments and services that people depend on. For so many Americans, the burdens of copays, coinsurance, and deductible-related fees are insurmountable barriers to accessing primary and mental health care, preventive services, and life-saving medications. And these costs are only rising. A 2019 report found that the average annual deductibles among covered workers had increased 100% over the previous decade. And for prescription drugs that people take every day, the price increases are even more significant, resulting in as many as 1 in 4 people with diabetes reporting that they are forced to ration insulin to save money. This insulin affordability crisis can be directly linked to disparities in health outcomes. Prevalence of diagnosed diabetes is nearly twice as high for people of color as compared to white Americans. Skyrocketing prescription drug costs are not unique to insulin, nor is diabetes the only disease more prevalent in communities of color. These trends underscore the urgency of passing legislation to lower out-of-pocket healthcare costs, not only to expand access to life-saving treatments, but also to eliminate glaring disparities in health outcomes across the United States. That's why last Congress, I introduced the Chronic Condition Copay Elimination Act, which would prohibit private insurers from charging any form of cost sharing for treatments and preventive services for conditions like heart disease, diabetes, asthma, hypertension, and depression. We need to eliminate the financial barriers that prevent Americans from accessing the healthcare services they need to survive. And by advancing policies like mine to do so, We will also reduce disparities for the racial and ethnic groups that suffer from chronic conditions at disproportionate rates. I look forward to reintroducing the Chronic Condition Copay Elimination Act soon, and working with my colleagues in the House and Senate, as well as health equity champions like you, to get this legislation passed and signed into law. Because while the cost of care is a health economics issue, it's also a health equity issue, and it's an issue that we must address if we're serious about eliminating racial and ethnic disparities in health outcomes in our country. Thank you again for the opportunity to join you for this event. I look forward to the day that we're back together again in person, but until then, take good care of yourselves.
Hi, this is Congresswoman Jamie Herrera Butler. Thank you for inviting me to participate in this wonderful event. I have the distinct honor of representing the 3rd Congressional District of Washington State in Congress. And let me say this, as someone who is constantly juggling many legislative issues and taking consequential votes every day, I need to hear from folks like you to do my job well. You're an expert on the condition that's impacting your health or your family's health. Sharing that experience with your elected representative can make a world of difference. I'm privileged to serve on the House Appropriations Committee. We're the committee that has the power of the purse. We set the funding levels for the National Institutes of Health, various programs under the CDC, and pretty much any other federal effort to research and understand diseases. In fact, I serve on the subcommittee that oversees federal dollars spent on fighting chronic diseases, and I highly value hearing from patient advocates from my community. Congress makes important decisions that impact medical research and patient programs, and making your voice heard during the process is critical. Here are some highlights from our 2021 spending plan. We're increasing funding for the National Institutes of Health by $1 billion from last year's level. We're also adding $500 million for cancer research, which includes breast cancer, lung cancer, pancreatic cancer, and others. This funding is critical for research and development of treatments for these life-altering diseases. I'm also working on solutions to support more successful organ donations for individuals living with conditions like chronic kidney failure. For example, I've introduced the Living Donor Protection Act, which would help remove barriers to organ donation, provide certainty to donors and recipients, and protect them from high insurance premiums. Organ donation has touched my own immediate family in such a positive way, and I hope we can make this life-giving gift available to more folks. Again, thank you for including me in this educational event. You have some great leaders involved in advancing research that will save lives. I look forward to continued partnership with you in Congress. Thanks and take care.
I'm Congressmember Judy Chu from California's 27th Congressional District, and as the chair of the Congressional Asian Pacific American Caucus, or CAPAC, I want to thank Good Days for hosting today's Minority Health and Health Disparities in America webinar and inviting me to take part. We know that even before the coronavirus hit, Asian American Pacific Islanders, or AAPIs, have had a harder time accessing care due to language, cultural, and geographic barriers. And this is one of the reasons AAPIs are disproportionately impacted by a number of diseases and chronic conditions, from diabetes to liver cancer. And though AAPIs make up 6% of the total U.S. population, we account for over 50% of those living with hepatitis B, which is a leading cause of liver cancer. On top of this, the disparities that AAPIs have faced throughout the pandemic have gone largely unreported due to a lack of disaggregated data that has often masked the challenges that certain AAPI subgroups are facing. But from the limited data we do have, we know that the coronavirus crisis has had a devastating impact on our communities. In just the first year of the pandemic, there was a 35% increase in the mortality rate of Asian Americans compared to the average over the past 5 years. On top of this, Native Hawaiians and Pacific Islanders are continuing to experience the highest COVID-19 infection and mortality rates in several states, including my own state of California, where the case rate for Pacific Islanders was consistently over 30% higher than the statewide rate. And despite pressure from AAPI leaders, 31 states did not release data on COVID-19 deaths in the Native Hawaiian and Pacific Islander population up through spring of 2021, which means that these communities are missing out on vital resources needed to save lives and contain the virus. That is why it's crucial that AAPIs are fully included in our COVID-19 response, which is something that I have been committed to as chair of KPAC. Last year, thanks to the leadership of Senator Hirono, KPAC helped to expand Medicaid eligibility to COFA communities. We in KPAC have repeatedly raised this issue with the president, vice president, and leadership at the NIH and CDC. And I'm proud that the American Rescue Plan that the House passed earlier this year provides $27 billion in funding to directly address minority health disparities. But I know there's more we can be doing, and that is why I'm so grateful for your ongoing work to advance health equity. Health disparities in minority communities can lead to complications, comorbidities, and overall poorer health outcomes. So thank you for all the work you do for patients with chronic conditions such as HIV, hepatitis C, retinal disease, and so many others.
Thank you to Congresswoman Chu for those thoughtful remarks, as well as Congresswoman Herrera Butler and Congresswoman Underwood for shining a light on issues of health disparities facing communities across America. I'm Julia Savicool. I'm the executive editor at HealthCentral. For those of you who don't know us, we are a website with 6.8 million visitors every month devoted to health and wellness content with a focus on supporting people with chronic conditions. We're really excited to be partnering with Good Days on this important panel discussion. The conversation about disparities in healthcare is of utmost importance to our audience. They know firsthand that access to qualified providers and newest medications can make or break the course of their disease treatment. Addressing health disparities in the US takes action on both the government and grassroots level and requires a coming together of people whose jobs or industries touch the lives of people with chronic conditions, from academic institutions to community health workers to your local pharmacist. This panel today hits on all of those notes. I'll let each of them tell you a bit more about themselves, but let me first introduce them. We have with us today Nelson Dunlap, who's a public policy manager for Morehouse School of Medicine, Eunice Junez, president and founder of Dia de la Mujer Latina, and Niat Nguyen, a healthcare supervisor at Walgreens and board member for Good Days. Nelson, let me start with you because you mentioned when we spoke earlier that one of the toughest barriers to get a government to enact policy change around health disparities is the argument that there isn't enough data. And that's something that Congresswoman Chu just alluded to with lack of COVID data for the AAPI community. So I wanted to talk with you a bit about your role in changing that conversation with the Health Equity Tracker. But before we go there, can you tell our audience just a bit about yourself and what you do at Morehouse School of Medicine?
Yeah, thank you, Julia. It's a great question. And I'm glad to be here with all of you this afternoon or this morning, depending on where you are. I'm Nelson Dunlap. I'm the Chief of Staff of the Satcher Health Leadership Institute at Morehouse School of Medicine. And I'm also the Public Policy Manager, in the Office of Government Relations at Morehouse School of Medicine. So I wear two hats, but really both hats are focused on addressing health disparities and health inequities under the lens and under the guise of, helping to teach and inform the next generation of healthcare learners and leaders at Morehouse School of Medicine. And Julie, what you mentioned was our Health Equity Tracker, which is a public-facing data platform that we recently launched just a couple of weeks ago, thanks in large part to the partnerships that we have with Google.org, CDC Foundation, Annie Casey Foundation, and Gilead Sciences. And really what this platform, this Health Equity Tracker, is designed to do is, again, to provide that data that we need to hopefully paint a broader picture of what health inequities and health disparities look like around the country. When COVID first kind of started to take root in our country, there was this moment where everyone was starting to really realize that COVID-19 was having a disproportionate and a disparate impact on communities of color, lower socioeconomic status, any really grouping of minority you can think of. We were being disproportionately harmed by it. We know that COVID-19 wasn't going out and attacking Black and brown bodies, rural populations. It's not sentient. It wasn't seeking them out, but rather it was those underlying disparities, those underlying determinants in our system that were being exacerbated and magnified by COVID. And, as you referenced earlier, for far too long, the story has been no data, no problem. So what we at Morehouse School of Medicine decided to do was, let's figure out how we can get our hands on the data. We can present you with the data, and then no longer can you ignore the problem. And so our health equity tracker, exists to do just that. It exists to pull in as much public-facing data in as close to real time as possible to really help people understand, on as granular of a level as possible, down to the county level, what disparities look like to them, what they look like around them. So right now, this is just version 1. We've got COVID-19, COPD, diabetes, uninsurance, poverty, some social and political determinants of health to really help you understand what's happening in your given county and compare it to other counties and other states around you to really understand what's going on. And in the conversations we've had with our partners, it's always been about making sure that the data scientists at Morehouse School of Medicine are able to utilize this information just as readily as, say, my grandmother in rural Kentucky. Because at the end of the day, the most important thing is to provide people with data, resources they need to survive and thrive during this moment, but most importantly, so that they feel empowered to really, influence policy in their own given sphere. So I welcome, anyone and everyone that can hear me to go to healthequitytracker.org, check it out, find some information about what's going on around you, and really try to get involved in the health equity movement to understand that even if you're doing great, your neighbor might be struggling, you might not understand why. And if you can see what's happening, you'll be in a better position to argue on behalf of those that you care for.
Nelson, can you give me an example of what a condition might be somebody could search for, or sort of a practical application of the tool?
Yeah, so the approach we've taken is a Mad Lib approach. When you pull up the health equity tracker, it's very kind of easy and intuitive. You'll be able to just kind of click through it almost in a sentence and say, I want to see COVID-19 in Fulton, Georgia, Fulton County, which is a part of Atlanta. And then you'll be able to see by race and ethnicity, sex, age, the breakdowns of that. At the same time, you can compare COVID-19 in a given geographic area with diabetes. So you can see that some of the same, neighborhoods, some of the same portions of our cities that are being ravaged by COVID-19 are also being ravaged by diabetes. And what are those underlying determinants? Why is that so? Why is the system making it so that the folks that are struggling the most with some of these chronic diseases are also being harshly impacted by COVID-19? And again, the goal is to provide people with information so that they can feel empowered to speak to power, to say, hey, my neighborhood, my population, my friends, my family, my loved ones, they're being harmed by the system. Something has to change.
That sounds like an amazing tool, and one I definitely think we will be using more here at HealthCentral, as well as I'm sure other people out there. Shifting gears a little bit, let me ask you another question, Nelson. One of the things we hear repeatedly from our chronic community here at HealthCentral, particularly among the Black and Latina communities, is a need for doctors who understand them and understand their culture. So I'm wondering what role Morehouse School of Medicine can play in this regard, and how the school is working to equip its graduates to maybe better understand or address health disparities in communities of color.
Yeah, that is a great question and a very pressing topic. Our president and dean, Dr. Valerie Montgomery Rice, she always instills in faculty, staff, and students alike that Morehouse School of Medicine exists to train, again, the next generation of healthcare learners and leaders, but most importantly, to be leading the creation and advancement of health equity. And when we talk about health equity, that's about being, culturally and linguistically competent. It's about meeting people where they are, providing them with the care they need in the amount that they need it, tailored care to reach their optimal level of health. And so we know, empirically, and we know anecdotally that people respond to providers that look like them. People respond to providers that understand their culture. They respond to providers that they can relate to. And we also know that even just looking, very narrowly at the number of African-American males in medicine right now, it's decreasing. There was a report that came out not too long ago that showed that in 1978, 3.1% of medical students were African-American males. In 2019, that was 2.9%. So it's gone down out of the 22,000 medical students, right? That's a staggering number. And so at Morehouse School of Medicine, we are dedicated to diversifying the healthcare workforce. So that's not just our MD programs, that's our MPH programs, that's our PA program, you name it. And again, that goes all the way down through our faculty and staff, because we know it's important for people to see in their communities providers, clinicians, advocates that look like them, that speak their language, that know their problems. Even outside of that, everything we do is focused on addressing health disparities and advancing health equity. So we've got a number of programs that represent this, even going outside of the racial and ethnic space when we talk about rural care. Take, for example, Georgia. Georgia is bigger than Atlanta. It's bigger than Savannah. There are counties that don't have any providers at all. And so making sure that our students have an opportunity to do rotations through rural Georgia. Our MPH students have the opportunity to go into counties and communicate with public health officials in rural counties so that they can see, hey, this is a career that I could do. And more importantly, so those communities can see Morehouse School of Medicine is dedicating to meeting us where we are to help us with our care. And even further, when we talk about the maternal mortality crisis, there's always an opportunity to address that. And we want to be on the forefront of that. So we've been building out a Center for Maternal Health Equity because, at the end of the day, it's about start to finish providing people with care, culturally competent, linguistic care that advances health equity. And so if we can help in the maternal mortality space, if we can help with our MD students, our MPH students, if we can help with our elder care, you name it. We want to make sure that anywhere we are, we're making sure that we're hearing from people, community engagement, understanding what their problems are, what they're facing, and figuring out how we can help them. Morehouse School of Medicine is dedicated to making sure that the next generation is even more culturally competent than the current generation, and so forth and so on.
Thank you, Nelson. Venus, let me bring you in here because I know a big part of your organization has to do with helping community health workers on the ground relate to, speak to, connect with people in the community with various chronic conditions. If we could start by just having you introduce yourself and tell us a little bit about how you came to found Dia de la Mujer Latina and what the organization is all about.
Absolutely, and thank you for inviting me. My name is Eunice Junez. I am the president and founder of Dia de la Mujer Latina. We founded the organization in 1997 because of my breast cancer experience and my sister's untimely death to cervical cancer. So we felt like it was in time for us to build a program that is very culturally and linguistically tailored. So we had the material, educational material, and we had our first promotoras training. So we developed the program and provided the signature Health Fiesta model for all these other communities, and we started to grow. We had such a success, and our first one was in Atlanta, Nelson. That's our home, and we just continue to grow into a form. Now we're 39 states. We're in Puerto Rico, Dominican Republic, and in University of Baja California in Mexico. So our program has been replicated all over, but we're meeting a need in our community. So, and I wanted to share something with you, Nelson. Thank you for bringing up data, because we in Latino advocates, we're concerned about data, how it's being collected, how it's being analyzed, and how it's being reported. Would you believe that there's 15% Hispanics and 85% Latinos? And people don't realize that. A lot of the educational material and all the propaganda, the promotional, even the infographics go to 15%. Many of our people don't even want to pick up the infographics because it's too much text and it's using verbiage that they won't understand. I also wanted to share that upon reviewing some of the informed consent forms, I have realized as community health workers, we need to share this with our community. And there was so many double negatives. There were so many acronyms. The level on these informed consent were 12th grade and above. And some of the translation into Spanish was horrible. And because we don't have anyone in the IRB to review this and say, this is not culturally and linguistically appropriate service, they let it go. And so we have somebody who's reviewing that, a Spanish informed consent form, and looks at the word that was translated literally for Black and African American, and they see negro, and they say, that's very rude. People don't even realize that that's a lot of these informed consent forms, that's what they have for the Spanish translation. So again, our promotoras are the ones that are capturing this, and I am so in awe with their work in our community, not only with cancer, diabetes management, but with COVID-19, they've been unbelievable great in our community, trying to get the word out on what misinformation is all about, providing them with verifiable information about what COVID-19 is, what's going on with our vaccines. And just to give you an idea how committed we are as a community, we developed the first COVID-19 training for community health workers in February 2020. This is before anybody else even thought it was news, including the administration. We were already developing the training, and over 3,000 people heard the training on March 5th. So I'm just saying that, if a small organization in Atlanta, together with all of these promotoras and community health workers, we were able to put this together. It's because we have commitment in our community, and that's what promotoras are all about. Community health workers are committed to empowering our community, to making sure that they are motivated to get the available screenings that they deserve, to inform them about the local resources, to navigate them through this complicated system that we have, and more than anything, educate them in a culturally and linguistically manner. So I am just so thankful to be given this opportunity to share the amazing work of promotores and community health workers. And I am their madrina.
Venus, how do we provide the community health workers with a sort of universal training, or training that can be applied across the communities that they all work in, and in the different languages that they use?
Well, in our case here in Texas, we have a certification training program available, and we don't care whether you are documented or not. You take the training. We were the first to be approved in the state of Texas, first Latino community organization to be approved to train in Spanish and English. So we have 8 core competencies: communication skills, interpersonal skills, advocacy skills, capacity building, service coordination, organization, knowledge base, and teaching skills. Those 8 core competencies, you can develop all kinds of curriculum under those 8 core competencies, and you will have a really good, successful program. Our program actually is on our website. Anyone can go to our website. I'll post it on the chat. They can download our training, because we are open and committed to everyone who wants to learn about these core competencies to reach out to us, because we're committed to our community.
Thank you, Venus. Niat Nguyen, you are also in Texas. You're a Walgreens healthcare supervisor and a board member for Good Days. The role pharmacists play in leveling the playing field for people with chronic conditions can't be overstated. So often pharmacists are the ones that are filling in missing information for patients on what they need to do for their care, and playing a critical role in speaking with insurance companies when drugs are prohibitively expensive for the patients. So Niat, welcome to our panel. If you could introduce yourself to our audience and tell us a little bit about your role with Walgreens.
Yeah, absolutely. And thank you so much for allowing me to take part in such a very important conversation. Again, my name is Niat Nguyen, and I'm the healthcare supervisor for Walgreens here in the Dallas area. I actually am a pharmacist by trade. And one of the things that I'm really passionate about with Walgreens and with outside of Walgreens is because my passion is so personal, is because of the reason this is the community. I grew up in a community as an immigrant in the Black, brown, and yellow, in the yellow minority communities. And that's the reason why I try to do everything I possibly can to not only strengthen operational excellence at the Walgreens Corporation, but also identify efficiency gaps, evaluate solutions, and also execute on processes and service improvement strategies. We do everything we possibly can at Walgreens in order to be able to ensure that our communities stay healthy, and they also are stay as well as possible. And so just really excited to be here today and be able to take part in this discussion.
Can you give us an example? There are many cases when a patient is prescribed a life-saving drug, but either insurance won't cover it, or maybe they don't have adequate health insurance. What role, if any, can a pharmacist play in helping the patient in that circumstance?
Yeah, so Julia, I think what you're referring to in the pharmacy world is known as specialty prescriptions, right? So these drugs are complex. Most of the time, they're expensive medications that require additional time and also expertise, not only from physicians, but from insurance companies, from pharmaceutical companies along with pharmacists in order to process prior authorizations, provide financial assistance, and also from a pharmacist standpoint, counsel and educate our patients. So I think it's pretty surprising for a lot of people to know that over 80% of those specialty prescriptions that we're talking about, those expensive medications, are processed through traditional retail settings. And oftentimes, the first point of care are for at these locations for our specialty patients. So obviously, these patients really need additional patient management resources in order to be able to treat their complex and most times their chronic conditions, right? So that's where we come in. We work both with our retail and specialty pharmacies. They work together to provide that seamless patient experience really across those 8,000 different points of care that are offered with Walgreens. And in addition to that, we place specialty pharmacies, that are able to help adjudicate those prescriptions conveniently, either within health systems or a lot of the times in a medical office building, along with in neighborhoods where physicians practice in order to provide services to those patients. We have team members in addition to that partner with healthcare providers, that partner with payers in order to ensure patients receive that highest quality of care, to provide services for those patients who have health conditions such as oncology, such as hepatitis C, HIV, multiple sclerosis. And then in addition to that, we also connect patients with assistant programs along with advocacy organizations such as Good Days, and they provide really resources for life-saving and life-extending treatments to people in need of access to care.
I know you've said many times money cannot be a barrier to care. The reality is that we've got 79 million Americans facing financial hardship due to medical bills, according to last month's Commonwealth report. And there's been a 34% increase in this country in medical debt in the last 15 years. Is the solution connecting with the patients with advocacy groups, or what? Is there a further role pharmacies can play in trying to help alleviate this financial burden?
Yeah, I think there's even more, that need is even more imperative, especially because healthcare and also access to specialty medications has been amplified by the pandemic, right? So every day we see so many individuals who were in this predicament prior to COVID that are in greater need of assistance. And unfortunately, too, just as many, if not more, Americans have found that they are in this position for the very first time. So I think I read somewhere, I believe it's 6 in 10 Americans today live with at least one chronic condition that requires multiple medications daily, right? And so pharmacists, and I'm a little bit biased in this view, but pharmacists, we have demonstrated just a really positive effect, in preventing medication errors and also limiting inappropriate prescribing. And so that really helps with reducing healthcare costs and really being able to prevent a lot of those hospital admissions and reducing hospital stays. What we're really talking is, from a perspective of community pharmacy, what we're trying to do is come up with a community-centric strategy to improve outcomes, really through proactive patient outreach. We also rely on community-based partnerships along with robust education. For community pharmacies in particular, we're trying to come up with creative solutions to really be able to address those social determinants of health. 45% of Walgreens' footprint is it's proximal to and currently serves areas of health inequities, right? So what we're trying to do is really change the approach that we are taking and taking a look at the population. Some of the questions that we're asking is, who's living around these stores? What are some of the health and social issues that, members of the community have? Can we possibly, in some scenarios, bring food in because we have maybe that platform? We're also taking a look at, do these communities have digital capabilities? We're also taking a look at, in some instances, some of those low-hanging fruits that sometimes we don't think about. Cheapest form of healthcare really is vaccinations. Can we possibly, take a look at vaccinations, or even for pharmacists, adherence? How can we possibly get patients to be more adherent to their medication so that we can drive down costs? But those are some of the things that we're taking a look at, to see what the population needs are in our community. When we think about education, we're also thinking about, again, going back to vaccinations. One of the challenges that we have is, do these communities believe in vaccinations? Do we maybe need to change up the conversation? In terms of adherence, is transportation possibly an issue? Do we need to possibly provide delivery? But obviously, we're not going to be able to solve this by ourselves, as community pharmacists. What we really need to do is leverage some of the partnerships that we have out in the community, partnerships such as Good Days, where they truly are able to provide that linkage to care in order to decrease a lot of those financial burdens that many of these patients have out there. And so those are some of the things that we are taking a look at, again, trying to come up with just creative and innovative solutions in order to address a lot of the needs in our community.
Venus, I know, thank you, Niat. Niat's comment about concerns surrounding the vaccine, and it makes me think of the role that the community health workers can play in that conversation. Have there been discussions in your organization specifically around the topic of COVID and the vaccine, and how do we reach the Latina community to ensure that people are getting vaccinated?
I'm glad you asked, because we have been looking at that for a while now. The issue in the beginning was not hesitation, it was access. A lot of them kept calling us, how soon can I get the vaccine? So there was no problem there until Johnson & Johnson. Then there was a pushback, and I don't know if the others felt the same way, but it took a while for us to get them back into thinking about getting the vaccine. What we decided to do is to set up a call center, and we have the first telehealth community navigation call center. It is specifically not only for community health workers and promotoras to get tips and strategies on how to reach the communities, but it's also a way for our Latino community to call us. They're talking to a promotora, a community health worker. They're also talking to a nurse navigator who can understand what their concerns are and not put them down because they're thinking this way, but really telling them that they're really happy that they are asking these questions, and that we are here to verify the information that they'll need. But at the same time, if access is an issue, then we can work with them. We have Uber available for them. We will have promotoras who will take them if they need to. So we have a system already in place with our telehealth community navigation program. And we started this program in April of last year, started just for the COVID testing, and now we're moving toward vaccines.
Thank you all. Right now, I want to start taking a couple of questions in our time left from our audience. Nelson, there seems to be a lot of interest in your health equity tracker. Vicky is wanting to know if, she says it sounds super insightful. Can anybody access it? Can you tell us if people are interested in using the tool, how to go about that?
Yes, anyone can access it, and hopefully everyone will. HealthEquityTracker.org is the URL. Hop on there. Again, it should be fairly intuitive and easy to use. Play around with it. But that said, if you go into our About Us section, you'll see an email. So if you notice anything that we're missing, any data gaps, we'd like to call out data gaps because that's part of the process, and we're continuing to build out a roadmap for what will come next. But as you're on the tracker, if you notice anything that we're missing, if there's any kind of access issues, anything at all, please do not hesitate to drop us a line in an email as our team is continuing to work on that. Because yes, this has been funded by external partners, but this is an institutional effort. Morehouse School of Medicine is supporting this. This is going to go on for a number of years. We've got our own technical team building it out now. So we're always looking for more and more content, more and more context, and more assistance from folks that are in the community to let us know, hey, this is beneficial, but only if I can get X, Y, and Z out of it. So please do not hesitate to reach out.
Awesome. Thank you, Nelson. We have a question from Taylor. Venus, I think it would be great if you could field this. She says, thank you for putting together this great event. What can we do to help in our own communities to help drive awareness about the need for culturally sensitive health needs?
I think it's important for any who has the time to start reviewing websites, information that's out there that may be misleading. A lot of misinformation is coming from all sources, even Facebook. We have a Facebook Live every Saturday at noon just to talk to our promotoras and make sure that if anything comes up as misinformation, we can get it out and get it verified, what they need to know. But I think one of the things that they can do is contact their local community health worker program. We're everywhere. And see if they can connect. And if not, they can go to our website, connect with us. We have a lot of networks that we've been working with. The National Association of Community Health Workers is another great place to look for some information. And then there's another program that we work with a lot. It's called stronger.org. And they're also tracking the misinformation. So if there's any questions about any information like that, that you can really drive the community to understand a little bit more what's going on. I think that's, look at some of those sites. But with us, we're here to help. And so come over and tell us what we need and we'll help you.
Amazing. One more question, Niat. This is for you. It's from Hannah Rose, who wants to know if you can tell us a little bit more about the role individual pharmacists can play in helping to promote health equity in local communities.
Yeah, so, this year, I think we've been able to showcase as pharmacists what we're able to do in the community. We are the most accessible healthcare providers out there. We're frontline. A lot of the times, whenever the public, prior to them make an appointment to see a provider, they actually come to us. And so, with pharmacists right now, we see our role as being didactful and very purposeful. With health equity, it really is being able to not only identify differences, but then also embracing differences. I actually help support, and I mentioned that I'm here in the Dallas area, and this area, Dallas is known for diversity. I have quite a few stores in the area that really help support, we have millionaires and billionaires coming into the stores. But on the flip side of that, the majority of my stores here in Dallas, the patients really struggle to even be able to afford a bus pass. And so, in addition to that, English is not the first language. And that's where a lot of our pharmacists are able to, provide information, provide services, provide resources in order to get our patients the care that they need and provide that access to care. We provide access to care no matter where you are, no matter who you are, and no matter where you live.
Thank you for that, Niat. It looks like we are nearing the end of our time for this conversation. Thank you guys so much for participating and sharing your thoughts on an issue that promises to become only more central to our country's discussion on healthcare going forward. I'm really happy HealthCentral can be a part of this discussion, and I encourage all of you to join us again for Chronic Disease Day in July. To continue our work with Good Days on this important conversation, you can go to chronicdiseaseday.org for more information on the July event. So as we say goodbye to Niat and Nelson and Venus, I want to welcome aboard Dr. Nathan Stinson Jr. from NIH's National Institute for Minority Health and Health Disparities. We are honored to have Dr. Stinson with us today for our keynote address. A bit about Dr. Stinson. He is a dedicated public servant with a career focused on addressing health disparities and promoting health equity. In addition to NIH, he has worked in public health at the Indian Health Service, the Health Resources and Services Administration, and the Office of Minority Health at HHS. Dr. Stinson received an MD and a PhD from the University of Colorado and has held faculty positions at Meharry Medical College. His awards and accolades include the Louis Stokes Leadership Award from the National Medical Association. It's fair to say he is highly accomplished, and we are very fortunate to have him joining us today. Health disparities, health equity, and diversification of health workforce are policy areas that Dr. Stinson has been leading on for many years. We appreciate him spending some time with us to provide an overview of recent advancements and emerging opportunities at NIH and HHS. NIMHD in particular has been working on innovative activities related to chronic diseases and health disparities. So please join me in providing a warm welcome for Dr. Stinson.
Well, thank you very much. Let me see if I can't share my screen. So I want to thank for the invitation to talk about NIH and the National Institute of Minority Health and health disparities regarding multiple chronic diseases. And I'm going to start out by telling a really quick story. As mentioned, I've been involved in issues around minority health and health disparities for a very long time. At one point in my career, I was the director of the National Office of Minority Health in the Department of Health and Human Services. And part of the responsibility of the office was an engagement in the Healthy People process. And one of the things that I noticed very strikingly is that, sitting through the reviews of the progress of different diseases, it became very apparent to me that in a lot of situations, even if the health in a particular disease state or condition improved, disparities continue to persist. Even after the investment of millions of dollars trying to target and try to develop, new programs to address it, it seemed as though we really weren't making that much, progress in really closing that gap. And in my own mind, if you're doing things, if you're making investments, seeking a certain outcome, and you're not achieving it, then you need to step back and think about why is that the case? What is it that you're doing that is not, achieving, the goal that you're interested in? And more importantly, recognizing that it's okay to say we're not going to do that anymore. We need to change, we need to pivot, and we need to focus in a little different area to try to achieve, the outcome that we're interested in. The other speakers today were just incredible. I know some of them. It's good to see them. They are individuals who have an expertise that is just so valuable in the work that we do at the National Institute of Health to try to improve minority health and health equity. What I really want to focus about is a new initiative that our institute is implementing this fiscal year. And I have to give credit to the Congresswomen who talked earlier in the program and their commitment and dedication, to elimination of health disparities, because Congress appropriated $45 million for this year to the National Institute of Minority Health and Health Disparities to really focus on and target health disparities in multiple chronic disease conditions. And they didn't just give that money for this year, they built that money into the base of our institute. And therefore, next year, the year after that, and the year after that, we can use these resources to really try to tackle, the problem of, chronic disease disparities. I don't need to tell anyone who is listening on this call about the significance of health disparities and chronic diseases. What we haven't done a great job in is really tackling those complex drivers of chronic disease health disparities. And from my perspective, complex problems require complex solutions. And I think we spent too much time trying to address chronic disease health disparities from a single focus, from a very limited view, by only addressing one particular aspect of what affects the overall health of individuals and communities. And so in this initiative, we're really focusing on really a transdisciplinary framework that really tries to cut across those different organizational, perspective and silos, and really take the advantage of what multiple disciplines can do together when they work very, very directly with the communities involved. And that really requires a very, very strong collaborations between researchers, community organizations, clinicians, healthcare system, public health agency, policymakers, other stakeholder, everyone that has a stake in what really happens in a community. And one of the things that I say very specifically is that, from a research or an investigative point of view, we can't go out into a community and say, we want you to be part of this research project. We want you to fill out this survey, trust us. We have to do things in the community before we even need one person to sign up for a clinical study to make sure they understand we are trustworthy. And that's why this whole idea of community engagement and community engaged focused research is really critical to the success of really trying to tackle health disparities. And the other perspective I just want to mention very, very briefly is a regional perspective. The issues that impact the health of individuals and create health disparities don't stop at a city limit. They don't stop at a county limit. They don't stop at a state limit. So where it makes sense, we need to try to determine how can we approach this problem from a more regional perspective. So I'm going to go fairly quickly because I know our time is really limited. But I really want to talk about this initiative that we're going to pursue this year that really supports regional comprehensive research centers on the prevention, treatment, and management of chronic diseases that are associated with health disparities. And the slide shows a list of certain chronic diseases. It does not include all of the chronic diseases that affect communities of color, unfortunately. But these are ones specifically that the congressional supporters were very interested in as far as accelerating the research. So I'm not going to talk much about the definition of what we mean by chronic disease, but I do want to talk about population with health disparities. NIH has a process of designating certain populations in looking at information in comparison to the general population that they consider to be populations with health disparities, and include the racial and ethnic groups, social economically disparate populations, underserved rural populations, and sexual and gender minorities. And there are other groups that we do know, if we look at the data, may also show, disparate conditions. And we're committed to going through a process of periodically looking at the data for new groups and seeing whether or not other groups can be designated as well. So just going through very, very quickly, what we're really interested in, we're interested in interventions. We know enough about the conditions where there are disparities. I mean, we don't need any more bad news about, here's another disparity, or here's the length of this disparity in this particular condition. We got a stark reminder of that with COVID-19 when it burst on the scene across the planet. What we really need to do is to try to figure out how to really focus on what to do about it. What are the interventions that will work and can be deployed out there in the real world and achieve that outcome that we're interested in, which is the improvement of individuals, health. And so we're interested in interventions that are tested and evaluated across the whole region, not just a single location. And we really want them to target to specifically reduce the disparities in the incident morbidity, mortality of multiple chronic conditions, or reduce the multiple common risk factors for multiple chronic conditions. Clearly, some of the areas that we know impact health disparities, such as structural racism and discrimination, is a particular area that we are also interested in. The hallmark of this effort is really designing the research projects and interventions that really focus in a multi-sectoral way, which means it requires collaboration across different types of organizations, in a community, and also a multi-level, multi-component intervention, so that we're not just trying to change an individual's behavior, we're also looking at the systemic things in the community that need to be changed as well if we're really looking to try to close that gap in any particular condition. Each center, has to really focus on, the co-occurrence of 2 or more chronic diseases. We didn't want this just to be focused on, a center on diabetes, or a center on, HIV, or a center on chronic lung disease. Even though we know those things occur, in health disparities populations. We want to basically say, okay, look, in these communities, these conditions are occurring together. We want an intervention that's going to really target multiple conditions, not one at a time. And we also, the other thing I want to mention in this thought is that we really, really expect that there will be a collaboration between investigators at the academic institutions and relevant stakeholders at the community level. There are several different components of these. Administrative core is just, it's, you need some hub that's going to be able to make sure that the center functions, in a coordinated way. I'm going to point out a couple of components and just mention very, very quickly, why they're important. Most of our centers that we try to establish have what we call Investigator Development Core. And this goes back to that, the whole discussion around creating that diverse workforce to either deliver care or to conduct research that's relevant to health disparities population. And we think one of the best ways to foster training is for people to work and implement a research project. And so our investigator development cores have pilot project programs where a small amount of money is given to early stage investigators to conduct a project from beginning to end. And we'll make sure that there's mentors for you. We'll make sure there's collaborators for you. We'll make sure the institution supports your effort. But you're responsible for this pilot project, and you get to learn, you get to know how to problem solve, and you get to design something that you believe will have a basic positive impact on closing the gap in health disparities. So the investigative development core is very, very important to us. Community engagement, the other panelists spoke very eloquently about the importance of that and also the benefits of doing that for the research efforts to be successful. And I just want to take a couple of minutes just to talk about the research projects, because this is kind of fundamental to centers. These centers are research centers, which means they all have certain type of research projects as part of it. And in this initiative, we're really, are asking for 3 projects, and we're talking about 3 real serious, projects that we think if they can be successful, they may have the ability to be, implemented in other communities, and those positive outcomes can be exported to other communities around the country. And at least one of these projects has to be a clinical trial. And when I talk about clinical trial, I don't just mean a drug trial. There are behavioral change interventions. There are other type of interventions that are clinical trials that are important in being able to improve the health of health disparities populations and close that gap. And again, as I've said, all along, has to be transdisciplinary, has to be multi-level and multi-domain. Health disparity is a complex problem. It requires a complex, solution. This is just a continuation where we give certain limits on, how much the project should be. Obviously, we're putting in $500,000 per project because we really want these things, to be to well thought out, well funded, and really designed to produce the results that we're interested in. Last thing I want to talk about is, as a companion piece to this effort, we're also establishing a coordinating center. We don't want these 8 or 9, health disparity centers for chronic disease that we established just to be out there doing, their research without any real connection, to the whole group of them. And we really want this coordinating center to foster the collaboration and communications between all these centers, and also facilitate ways that they not only can network, but they can use the information that they are collecting in a way that really does inform not only NIH, but other funders and policymakers on things that actually work. There's a data activity, skills development, which goes to the workforce again. And of course, in all of our programs, community engagement is a very prominent feature. In the last 2 or 3 slides, I'm just going to say is that, we think information is very, very important. Several of the panelists talked about the challenges that they have when there is not sufficient information. So part of this effort is to develop systems, to collect information and data in the appropriate and respectful way, and also do it at a granular enough level where it actually can provide us an information among the groups of health disparity, populations. None of the racial and ethnic groups are monolithic. They represent, individuals from different ethnic and country origin, which are important as far as looking at what we can do to improve the health. Skills development, again, is just, what are the things that we can do to really build that diverse workforce for the future. And in community engagement, just such a critical thing, to really be able to address minority health and health disparities. That's my last slide. I just want to, again, emphasize. I want to again emphasize that complex problems require complex solutions. We've made a considerable investment in minor health disparities. There has been improvement, no question about that. But there are ways that we actually can think about doing things in a more coordinated way that I believe will actually accelerate our efforts in trying to close that gap and improve the health of everybody in the country. Thanks you very, very much for this opportunity.
Thank you very much, Dr. Stinson, not only for all the work you've done, but also for what you're doing at the National Institute of Minority Health to help us all better understand health disparities in minority communities. And it's alarming as we continue, and I think that there's many things we can do. One of the words I like that you use is prevention. So many of the chronic illnesses that the African American, Hispanic community, Latina communities are suffering from are things that we can help them with to prevent those chronic illnesses from coming. Again, when you look at the Hispanic community, if 8 in 10 are considered to be obese, then very likely at some point in their lives, high blood pressure, diabetes, and many other things that are going to lead to a lower quality of life. And so part of what every one of us are doing, I think education is going to be at the forefront, and ensuring that, when we're looking at just talking about the Hispanic community, when we look at getting together, it's always surrounded with food. And so, we're very happy people, but there are things that we need to do culturally to change the number and to reduce the events of chronic illness across the board.
Yeah, I think that's just so critical, to really be able to do that. And I just do have to say, having the Congresswomen come here and talk about their commitment to this is very encouraging to me. It's encouraging because, there are more advocates who get the importance of addressing chronic diseases, in populations around the country. And that type of support is just invaluable as we try to, do everything we can to make sure everybody has opportunity for a full and healthy life.
Yeah, and the more discussions like this that take place, I think the stronger our reach is going to be. And it's been said many times, it's hard to do something when you're standing alone, but when you have a large community behind you, we can make a lot of progress.
Yeah.
So thank you again for joining us today.
Sure.
I would also like to thank Representatives Underwood, Butler, and Chu for everything they're doing on behalf of the chronic disease community. HealthCentral for partnering with Good Days to make this live stream possible, and Julia for moderating. I also want to thank Nelson, Venus, and Niat. From a pharmacist perspective, what Niat said really hit me, and they are really the front line of healthcare, the easiest healthcare representative to get in front of. And the work that I've seen in the various pharmacies that I've visited, and from a pharmacist perspective, what they are doing, it's certainly impactful. And having worked in healthcare all of my life, she hit the note really hard. Many people, prior to coming to their provider's office, they'll talk to their pharmacist. So again, thank you for everything you're doing on the front lines. And Venus in the Latina community, you're also teaching organizations like Good Days how we can better communicate with the different types of communities that we support. And Nelson with the Health Equity Tracker. So there are so many different ways entities can use this information. And when I am looking at it from a charitable perspective, it'll help me better understand what different communities' needs are. So thank you everyone again. And lastly, for all that are listening, if you can tune in on July 13th at 12 Central for Chronic Disease Day signature live stream event. Thank you again for joining us. Take care.